I can hear you, and I can hear and see your screen. Your first slide, Thymic, Stromal, Thymic. Yeah, your slides are advancing.
Okay. We're going to get an echo because I'm on two computers. I'm going to get off of one of them right now.
Okay.
All right. I think I'm ready to go. Whatever you want.
Anytime, I'll just
Can you hear me still?
quickly say John Corren's been a friend and a colleague up here many times in person, and this is a very timely presentation. And go ahead and take it away.
Okay. Thank you, Len. Appreciate it. And wish I could be there with you guys up in Seattle and other places as well.
A little louder.
Can you hear me?
Yeah, just speak close to the microphone.
Okay. I may be able to crank it up a little bit. Hold
Okay.
on. Okay, I'm shifting over to a mic, which may give me a little audio. How is that?
Excellent.
Is that a little bit better?
Better. Yes.
Hello?
Yeah, it's better.
Hello?
I hear you.
Hello?
I hear you.
Len, can you hear me still?
Yes, I hear you. I don't think you hear me. You hear me?
Hello?
For what it's worth, I can hear both of you.
Who's that?
This is Herb Lara at Amgen.
Okay, let's get started. Somebody just kindly sent me an email saying you can hear me.
Okay.
So we're going to talk about, I agree with Len's comment that this is a topic that's extraordinarily timely because we're now in a position to have a pretty good handle on the biology of this, along with understanding how we may potentially antagonize it. You know, in your own neighborhood up in Seattle, you have probably the world's expert on TSLP who has done much of the foundational work on working out the biology in mouse models and now much more recently in humans as well. So we're going to dig into some of the biology of TSLP, which goes by the full name of Thymic Stromal Lymphopoietin. We're going to get a little bit into the issue of how TSLP relates to the atopic march and why that may be important potentially downstream or in years to come to earlier interventions with strategies that may block TSLP if we can do so safely. Then move into the role of TSLP in asthma and look at some of the studies that use specific agonists in order to stimulate asthma and some asthma-like processes and why this may be important to targeting TSLP in patients who have severe asthma. And then finally, look at some of the more recent data with clinical trials that have been published to date and discuss perhaps why this may be a promising strategy. So now we're going to enter upon the biology of TSLP and try to understand the molecule a little bit better. And we'll start with some general considerations. So this is a 4-bundle helical protein. It's probably not of great interest to most of us. It is a paralog of IL-7. This becomes important because it shares the IL-7 receptor alpha subunit along with the so-called TSLP receptor, which is distributed on a large number of cell types, which makes sense because this is a very highly upstream molecule. So we have to go back probably 25 years when there was a recognition that in cell cultures, there was an activity identified as a lymphocyte growth factor, which had effects on both B cells and T cells. And then later, through a lot of in vitro work, it was recognized to be very important at the interface of the organism and the environment. And some of the very rich sources identified for TSLP were in the lung and gut epithelium and in keratinocytes. Now, this cytokine has been grouped with interleukin 33 and interleukin 25. These are all termed the alarmins. And what we've learned about these three molecules is that they are released by exposure to allergens, particularly protease-containing allergens. And this is something that really we're still working out and don't have a good handle on in humans, whether all allergens have the same capacity to release TSLP, IL-33 and IL-25, or whether, in fact, there has to be some component of protease. A variety of microbes, particularly viruses, bacteria appear to play a role as well, and parasites. And this is a theme that's shared greatly in common with things like other components of the Th2 system, where eosinophils and IgE and mast cells seem to be prominently involved. Pollutants, particularly tobacco. Tobacco has been shown to be a very robust stimulus of TSLP release and seems to upregulate the amount of TSLP. And in fact, render the system to be somewhat steroid unresponsive. So this certainly gives rise to thoughts about employing this molecule or inhibitors of this molecule in patients who smoke and potentially have COPD or a COPD asthma overlap. And then finally, injury, which is not so much relevant to the lung, but certainly very relevant to the skin, where there are lots of studies demonstrating that abrasion of the skin, and very often in animal models, we use a technique called tape stripping, where damage to the most superficial level of the skin and removal of those cells causes a very robust release of TSLP into the system, not only locally, but systemically. And this, in fact, plays into the whole idea of an atopic march. So we've mentioned the epithelium as the major source, but there are minor sources. We know that dendritic cells, once activated by TSLP, can themselves release TSLP. Mast cells become a very important source. Fibroblasts, which are a key structural cell in the airway. And interestingly, smooth muscle, because there may be direct effects of TSLP on smooth muscle. We know certainly more downstream molecules like IL-13 have a very strong effect on smooth muscle. And once activation occurs, these cells all begin to produce TSLP, albeit not in the level of the epithelium, but you now develop a system where inflammation will help sustain the release of this upstream cytokine. And this is just a little bit of data getting into the idea of trypsin, a very strong proteolytic enzyme, on the relative expression of TSLP mRNA. And we can see a very nice dose response, which, if we look to the right, mirrors what we see with alternaria, a very important allergen to asthmatics, predominantly released in the fall and associated with severe exacerbations. And we find similar type phenomena with aspergillus, which then allows us to sort of ask the question, might TSLP be one of the key factors in patients who have aspergillosis? And in my opinion is that it does. And we know that early on in development, particularly in some of the foundational work that's been done in mouse models, the type of trigger is very important to the TSLP that is released. And this is a TSLP deficient mouse model. What we're looking at are effects on ILC2 cells during the sensitization phase. So this is not like a human with established inflammation, but this would be like a neonate where we're trying to engender inflammation using a variety of means. When we use ovalbumin in the presence of TSLP in a TSLP knockout model, we don't see activation. So at least in this particular model, we're not seeing, in the absence of a protease, any kind of upregulation of ILC2 numbers or activities. But if we then combine TSLP in the same model and inject it with papain, which we just showed in vitro has strong effects, we do see ILC2 activation. And keep in mind that ILC2 is one of the most important target cells for TSLP that's been identified to date. So here we're looking at immune cells. We're not looking at structural cells like fibroblasts or smooth muscle. And we're looking at epithelium, a dendritic cell reaching out one of its pseudopods to sample the external environment. And on the left, we're looking at potentiality of allergen to stimulate the system. On the right, some of the known non-allergic factors that we've discussed. And probably the most heavily studied phenomenon relating to TSLP, particularly during early stages of immune development, are the interaction between the dendritic cell and the naive T cell, resulting in the development of the Th2 cell. And in the absence of TSLP, this phenomenon can happen, and we'll dig into that a little more in just a moment. So certainly the dendritic cell, that arrow is trying to reach the dendritic cell, has a very positive upregulatory effect, as does TSLP on Th2 cells. We know the products of Th2 cells, mast cells, and ILC2 cells, the canonical type 2 cytokines, particularly IL-5 and 13, that IL-5 is responsible for recruiting eosinophils into the airway, and we see direct effects of TSLP on eosinophils. If we move to the right, basophil would probably be one of the other more important cells involved with TSLP, and I'm going to go into some of the reasons for that in a moment. And we've talked about Th17 with subsequent release of IL-17 and Treg cells with the release of IL-10 as being potentially upregulated cells. But if you look at the literature on this, it goes both ways, particularly in humans with a variety of disease states. So now let's try to get into some of these particulars as we explore this. So when we look at T cell priming, the most proximal effect of TSLP on the immune system is upregulation of OX40 ligand, which is shown in green coming out of the dendritic cell, CD80 and CD86. These are all critical in activating naive T cells. And what's interesting is expression of the TSLP receptor on these T cells does not require prior activation of cells, which means it's something that can happen early in sensitization, whether that sensitization occurs in the first couple of years of life or somewhere many years later. This feature is very different from what we see with interleukin 33, where cells have to be activated in order to express that receptor. And what we've done is worked out through animal models a paradigm wherein activation of the dendritic cell secretes interleukin 3, which then activates the basophil. This takes place in all likelihood before there is any IL-4 released by T cells or other cellular sources. So this indirect activation of basophils becomes a very important source of IL-4 early in the state of sensitization. And that IL-4, in conjunction with the binding of the OX40 ligand and the OX40 on that T cell, allow promotion of a Th2 phenotype. So we don't hear a lot about this TSLP dendritic cell basophil interaction, which is probably in fact quite important. Once you have these Th2 cells that have arrived upon the scene, there is an induction of further proliferation. So that helps perpetuate this by TSLP and an increase in cytokine release. So even if you can't affect the sensitization, you can affect the propagation of inflammation and the persistence of this cytokine milieu that allows this process to continue. What about some of the other key immune cells? We don't hear much about TSLP in mast cells, but some work that we've recently done using patients with cat allergy, I think, has helped demonstrate a very important role for this cytokine in mast cell development, in mast cell growth, in the release of mast cell-derived cytokines, including IL-5 and 13. And this may play a role particularly in non-allergic or non-type 2 asthma, which we'll talk about later. ILC2 cells, as I mentioned, are an important target. This is a key survival factor, something that it doesn't have in common with IL-33. IL-33 has much more, or we'll say lesser effects on the survival of ILC2 cells. And again, TSLP is capable of increasing the release of cytokines, including IL-5 and 13. Another thing we don't hear a lot about are the direct links of TSLP to eosinophils, and there are some effects that have been studied that go back more than a decade. A delay in eosinophil apoptosis, an enhancement of eosinophil adhesion through VCAM1, and an increased release of IL-6 and some other chemokines. And this release of IL-6 becomes very interesting, again, because of its potential role in non-type 2 asthma, as well as some other disease states. As I mentioned, for the Treg, the data really indicates both up and down regulation. Our hope was that if TSLP really suppresses Treg formation, then blocking TSLP would allow you to increase the number of Treg cells and hence perhaps work in conjunction with immunotherapy and develop a nice strategy for immune modulation. And we're still trying to find out how relevant this is to humans with allergy. Th17, again, seems to relate to the target organ, and something, again, we haven't heard a lot about are the itch factor that TSLP plays. It's a pruritogenic factor that stimulates itching in neurons directly without having to invoke IL-13 or IL-31. So again, this is something that may play a role in the engenderment of atopic dermatitis. Now, we've read a lot about TSLP isoforms, and we recognize that there is a full form on the left and a short form on the right, markedly truncated, but with two of the same main chains. So we've recognized that there is a second TSLP mRNA, which encodes the very end of the TSLP molecule, the last 63 amino acids. This has been referred to as the short form of TSLP. Something that's important is we recognize that there is constitutive expression of this RNA, both in bronchial and colonic epithelial cells, in the skin, and in lung fibroblasts. So it potentially could be important. It's something that's seen primarily in humans, not so much in other species that are studied. And the evidence against the functional role of short form is that there's very little evidence for expression of a short form TSLP protein, I should say translation, that we don't really see the full protein, at least in vivo. A second factor is that short form TSLP mRNA expression is unchanged after factors that normally upregulate TSLP, like lipopolysaccharide. And finally, and very importantly, there's no known receptor that's been identified for the short form. So at this point, what I'm going to be talking about is the full form of TSLP. So what about the atopic march? When we look at children with eczema, we know about 50% will go on to develop upper and potentially lower airway allergic disease. And there's some very interesting data which relates to the role of TSLP in inducing a systemic illness. And here again, we're going to go back to animal models, and we're looking at the role of abrading or damaging the skin. In this case, we're going to use a vitamin D analog directly on the skin of the mouse. This is followed by a lung allergen challenge, and the mouse ends up with asthma with specific sensitization to the antigen that was used in the challenge. So of course, we have to try to negate this effect. And by adding an anti-TSLP blocking antibody, indeed, we find that this process does not result in asthma, going through the exact same steps that we previously went through. So if we take this model and dissect it out a little bit more, we can take, in the absence of vitamin D or any stimulus, non-specific stimulus, we'll actually take skin antigen in this case, in a TSLP knockout mouse, and add TSLP. Once that's had a chance to exert its effects, a lung allergen challenge is performed, and again, the mouse ends up with inflammatory and bronchospastic airways disease. Now, what's interesting is that neither the TSLP production of lung nor circulating TSLP was required to trigger an asthmatic response upon subsequent allergen challenge. So once the system has been established, we then learn that it then becomes a self-perpetuating system. And secondly, that both CD4 T cells and provocation with the allergen used in this case were required during the challenge phase, and that this asthmatic response was in fact antigen specific. So we then have an idea how the systemic circulation connects the skin, which may be the original organ involved in atopic disease, spreads through the blood by the lung, into the lung, potentially through these cells in the presence of TSLP, at least initially. So what are the lines of evidence that tell us TSLP is in fact involved in asthma? There have been a limited number of genetic studies. There have been some nice provocational studies looking at specific triggers. And there's been some very good work that have looked at relationships between TSLP levels and asthma severity, lung function in the asthmatic, and particularly the phenomenon of glucocorticoid responsiveness. So let's start with some of the genetics. There have been a number of genome-wide association studies that have looked at a variety of single nucleotide polymorphisms. And when you look across all of this data in total, it's yielded a lot of mixed results. And this has related to the size of the studies and the representation of different ethnic groups, because ethnicity may play a role in this. The largest study published to date back in 2011 in Nature Genetics employed a meta-analytic approach. It used a number of databases from North America and employed genome-wide association studies. This was done in children and younger adults who had a history of childhood onset asthma. In this study, they did identify a particular SNP that was significantly associated with asthma risk in 3 different ethnic groups. And when a similar study was done in Japan, the exact same locus was identified as a susceptibility locus in a group of Japanese patients. So certainly this may involve both patients of Caucasian origin as well as people from Japan. And when you look at some of these studies, what you're left with is the impression that the percentage of patients with asthma who have this SNP is relatively high. And it gives us a nice hypothesis that this, in fact, is a genetic deregulation that is bestowed upon us early in life, and probably through epigenetic modification, allows some of the patients to develop asthma. So if we look at specifics, and here we're looking at bronchial allergen challenge, and I chose to present this first because certainly the work in allergic asthma with TSLP is probably the best evidenced. And what we're looking at is before and after antigen challenge. This is whole lung challenge in humans. And we're looking at left at the TSLP in the submucosa. And we're looking at before and after allergen challenge, and we're looking at TSLP positive cells. And we can see that there are a large number of cells that are bearing TSLP. If we take that and in the same group of patients and look at the relationship between TSLP bearing cells, and this is at baseline, and look at the FEV1 before challenge, we find that there's a very, very nice correlation coefficient above 0.5, which was statistically significant, looking at the baseline set of conditions that patients will have before they undergo challenge. So you have people who are both high and low TSLP. This seems to relate to their level of lung function. And keep in mind, this is a group of patients with relatively mild asthma. And then if we finally move to the far right, we're looking at the total number of cells that are positive for TSLP after challenge. And we can see that there's a movement of these cells comparing before and after towards the right, indicating a larger number of cells. And again, an even higher correlation coefficient with FEV1. So we see an increase in a period of 24 hours after bronchial allergen challenge. And we see a strong correlation between these positive cells for TSLP, which is in existence both before and following allergen administration. What about viral infection? And what we're looking at on the left is actual TSLP protein. And we're looking across a group of patients. We're looking at healthy controls, healthy patients who have been exposed to RSV-19, patients who have been exposed to RSV-A2, a group of asthmatic controls, a group of asthmatics who have been exposed to RSV-19, and then finally RSV-A2. And what we can see is that in this in vitro or in vivo sampling of patients that there's a nice dose response between the amount of TSLP protein in lung tissue according to these various groups. And we can see that RSV seems to have a significant effect on airway TSLP, particularly in patients with asthma, as opposed to patients who are healthy controls. In some in vitro work that was subsequently done, we can see that the addition of IL-13 to this system, and in this case, rhinovirus versus IL-13, and then the combination, seems to have an additive effect on the release of TSLP. Now, we've read and heard about non-allergenic factors potentially being of importance in patients who have chronic asthma, and how TSLP ties into this whole non-allergic agonist system. There have been some nicely done studies with cigarette smoke, CSE being cigarette smoke exposure. And if we look at the far left, we see that exposure in vitro, TSLP, or to 2% cigarette smoke exposure, we see that TSLP actually is released, and this is from a smooth muscle preparation. So again, as we saw early on, with the right kinds of activation, structural cells have the capability of releasing TSLP. We see in the middle panel that there's actually a dose response. As you go from 1% to 2% cigarette smoke, you get an increase in this case, not the amount of TSLP released, but the actual amplitude of the smooth muscle constriction. So we've jumped from TSLP release from the smooth muscle to that same agonist having an effect on smooth muscle constriction. And then if we try to tie these things together by using an antibody to TSLP in the presence of 1% cigarette smoke exposure, we see a blockade of this constrictive effect on the airway. So interestingly, we have a nicely done experiment which really does demonstrate, at least in an in vitro fashion, how cigarette smoke works through the TSLP axis and has actual direct effects on contraction. Now, using Koch's postulate, but now shifting it away from infection just to chronic disease state manifestations, we have to identify TSLP in the system and correlate it in some fashion to either the presence or severity of asthma in order to really make a strong case that this is a critical component in the system. So what we're going to look at is this relationship of airway TSLP, asthma severity, and lung function. So if we look at the left, we're seeing TSLP levels in protein taken from the BAL fluid of 4 groups of patients. Healthy controls, where we see a pretty nice clustering within about a 1 log difference between the group. We have asthmatics who are not taking any inhaled corticosteroids. And interestingly, we have a cluster that's pretty uniform, but there's a group of patients that don't have much TSLP at all. So we see sort of a bimodal distribution of TSLP protein. As we start to shift towards a more severe picture, we see patients taking inhaled corticosteroids, again, have a similar value to the group of patients with mild asthma. But with the exception, there are almost no patients in this group that have the absence or near absence of TSLP. And then when we finally get into the group of patients who have oral corticosteroid-dependent asthma in the presence of topical application of corticosteroids as well, we now see that the median level goes up. And interestingly, all of these patients, without a doubt, have an elevated level. So it gives us sort of an inclination that this group of patients tend to have more TSLP release as they have more severe asthma, and that in the presence of corticosteroids, we don't see a blockade of this release, at least in this small cohort of patients. How does this play out functionally using Koch's postulate? Well, we see a relationship in humans between TSLP and FEV1, not only pre and post allergen as we saw before, but again, at baseline, a very nice relationship. Now, we've gotten into the issue of corticosteroid resistance in airway TSLP a little bit by looking at that last data. What we're now going to look at are a group of patients that have had BAL fluid taken, and in this case, ILC2 cells removed. So we're going to look at some ex vivo work, looking at the relationship between those cells and the amount of TSLP correlated with the presence of those cells in BAL fluid and the ability of dexamethasone to suppress key functions of those cells, in this case, cytokine release. So if we look at the graph, we can see as TSLP goes up, the amount of dexamethasone suppression in ex vivo goes down dramatically. So high TSLP expression from the airway seems to be associated with the reduced sensitivity of these cells to dexamethasone. And at the same time, there are other peripheral phenomena central to the type 2 biology of asthma, that this resistance was correlated with both higher sputum eosinophils and blood eosinophils, and a lower FEV1. That data is not shown here, but this is a great paper written by Lou a couple of years ago in JACI. And I think it really does complete the story that TSLP really sort of leads patients to this point where they don't respond well to normally inflammatory suppressive therapy. So this now takes us to the effects of TSLP inhibition in asthma. And the molecule that has been used in clinical development and is now completing its phase 3 trial is a monoclonal directed against TSLP called Tezepelumab. This is not a humanized molecule, it's a fully human monoclonal, which binds to TSLP with a high degree of affinity, highly specific, and the half-life allows for dosing every 4 weeks. And work that's been done shows that you get very, very strong suppression in vitro of functions related to TSLP using this monoclonal. And several years ago, there was a study published by Gail Gavreau from Paula Burns' group, published in the New England Journal of Medicine, where they did a proof of concept study employing this same anti-TSLP, Tezepelumab, on allergen-induced asthmatic responses. And I will preface this study presentation by saying this has been the graveyard of many a drug. And I think we've moved away now from using the allergen challenge model as a first-line test of a drug, primarily because there have been reasonably good molecules, including lebrikizumab, in fact, which I still think has therapeutic value, in really having very minimal responses in this model. So if we look at the effects of Tezepelumab on the challenge model, this was a parallel design study. It was a group of mild allergic asthmatics. The N, which is left off of here, was approximately 17 in each group. 3 doses of Tezepelumab were administered. This is not the same dose that was employed in the phase 2b study. This was 700 milligrams IV given once a month. And the primary outcomes of this early phase study were the early asthmatic response and the late asthmatic response, along with some key biomarkers. If we look at the study schema, we can see that AMG 157, which was the original name of the molecule, this is a molecule created by MedImmune and Amgen, and now in conjunction with AstraZeneca, are all developing this drug. There was an allergen challenge at baseline, at which time there was a pre and post airway hyperresponsiveness measurement, along with biomarkers, including blood eosinophils, sputum eosinophils, and exhaled nitric oxide. First dose of drug is given. You can see that subsequent doses of drug are given every 28 days. The first allergen challenge was after being on the drug 6 weeks, and the last allergen challenge was performed about a month after stopping therapy. Any questions at this point? So if we look at the outcomes, looking first at pulmonary function on the left and then biomarkers on the right, and we can see at baseline, day minus 14, then we have 6 weeks and 12 weeks into the study. And what do we find? We see that there is, in fact, a reduction in the late phase response. And interestingly, there is a reduction in the early phase response as well, shown in red. This is after 2 doses of the drug. When we then get out to about a month after the last dose of drug, we find that suppression has not necessarily waned, but is actually even better, which speaks to the pharmacodynamics of this molecule. And certainly would have been interesting to look at another 3 months out. What I think came as a surprise from the perspective of physiology is that there was such a strong effect on the early phase, because we sort of characterize this molecule TSLP as a trigger of type 2 inflammation and oftentimes don't think about the mast cell effects. But this effect at day 42 would not have been attributable to IgE present on mast cells, but rather would have had to be a direct effect on the mast cell itself. If we turn to the right and look at markers of type 2 inflammation, we can see in blue the placebo, and we can see with regard to blood eosinophils, when you have a challenge shown in black, you get a spike in blood eosinophils in patients that are treated with placebo. And we see, interestingly, that starting from the very beginning, that there's an actual reduction in blood eosinophils. And we then see that that rise that were accompanied by the allergen challenge is completely blocked by the effective drug, which gets back to the idea that even far after sensitization has been accomplished, you're still having a moderating effect on cells that are probably important, including ILC2s. If we look at sputum eosinophils, we see the same phenomenon, that after drug is administered, and that's indicated by the red arrow, that there's nearly a complete blockade of sputum eosinophilia. And similarly, if we look at exhaled nitric oxide, if we go from the very beginning, there's actually a reduction in nitric oxide from the start, with only small blips upward following allergen challenge. So from this study, we conclude that at least in the acute setting of allergen, similar to what we saw before, there is a blockade by Tezepelumab, which is associated with a complete blockade or near complete blockade of the generation of these critical type 2 biomarkers. So with that as a background, needless to say, people that were charged with the development of this drug were quite excited, and this drug went on into dose ranging. And the results of that dose ranging study were published in the New England Journal of Medicine. Adults with severe asthma who had poor control with frequent exacerbations. Again, the study timeline and the population that we employed. These were adults above age 18. All patients had an ACQ of greater than or equal to 1.5. Patients were required to be on medium or high doses of inhaled corticosteroids plus LABA, or inhaled steroids plus another medication like a leukotriene modifier. They were required to have more than or equal to 2 exacerbations or a hospitalization during the prior year. And it was an interest to see whether inhaled corticosteroid requirement, which could infer some degree of steroid unresponsiveness, might be an issue. So they were stratified by both medium versus high dose steroid, by eosinophil counts above and below 250. You might ask yourself, why not 300? 250 probably more closely approximates the cutoff for type 2 biology. And then finally, location. For regulatory reasons, the study was divided into the US and Japan. So patients came in on their background medication. It was a 52-week period of study. Patients were randomized to either Tezepelumab 280 every 2 weeks, given sub-Q, almost reaching the dose that was given in the phase 2A study of 700 milligrams, 210 given every 4 weeks, 70 given every 4 weeks versus placebo. If we look at the demographics taken straight out of the article, we can see that if we sort of go down the list and look at some of the biomarkers that we're used to looking at, the median eosinophils, which is about 2/3 of the way down, were in the high 200s. The total serum IgE in the median level was in the low to mid 100s, and the exhaled nitric oxide median was in the low 20s, with the mean value, because of outliers, being up into the mid 30s. So these results are not so dissimilar from studies we've seen before. It may in fact differ from some of the studies we're used to looking at, because this was an all-comers population. So one thing, whereas the study was stratified by entry-level blood eosinophil count, there was no requirement for a blood eosinophil count. And in fact, there was an attempt to match both people with high and low eosinophils in the study. The primary outcome of the study was asthma exacerbations, and now we're looking at the non-stratified population. And we're seeing across these different dose levels, somewhere between a 61 and 71% reduction in exacerbations. What's interesting is the placebo group had a very low level of exacerbations, 0.67 exacerbations per patient per year. Some of this may have related to a large number of study patients being enrolled from Eastern Europe, where perhaps it is more difficult to get controller therapies. And as part of being in the study, they were equipped with inhalers to control their asthma. And hence they went from an average of 2.5 exacerbations in the year prior to 0.67. But notwithstanding that robust placebo effect, we see even a greater effect on active drug. So this really became the challenge. With such a strong placebo effect, could we actually outdo that? And that was the case. And what I will comment on is that these levels of exacerbation are lower than what we see in other studies of biologics. Now, the caveat is we really can't do head-to-head comparisons. This is a historical indirect comparison. But typically, we do see exacerbation levels getting down to the range of 0.4 to 0.6 in patients who are actively treated. And that effect really should be independent of what the placebo is doing. That's really an absolute effect on lung biology. And I think we'll have to keep these in mind as we move into the phase 3 results, hopefully sometime early next year. Now, something we don't typically even examine early in study development is what effect a drug has on hospitalization. Typically, we have to wait for phase 3 results in order to see a large enough group. And interestingly, even though there was a lower exacerbation rate, some of these people were very severe, and these are the people that ended up getting hospitalized. And there was a 0.13 hospitalization per patient per year rate seen in this study, which, as we can see in all 3 doses, consistently across the Tezepelumab arms, there were significant reductions, with the majority of these hospitalizations prevented. What was the most interesting part of this, and I think the reason that it was of interest to the New England Journal, was the fact that this wasn't just a drug that blocked type 2 inflammation and type 2 exacerbations. So if we try to break down the group by eosinophils, and here we're looking at EOs above and below 250, by exhale nitric oxide above and below 24, and by a Th2 surrogate, which had been employed in the Genentech studies of lebrikizumab, which constituted an IgE above 140 and an eosinophil count above 100, we can see that we have different levels of placebo reactivity with exacerbations, but no matter what you look at, whether it's above or below, for these 3 different markers of inflammatory activation, you're seeing a suppression. Implying that this drug may very well have utility in non-type 2 asthma. Interestingly, if you look to see what are the best markers differentiating above and below the cutoffs for exacerbations, certainly FeNO seems to be a good marker, with lower FeNO really being much less exacerbation prone, and high FeNO above 24 having a level of 1.0 exacerbations per patient per year. And this has been borne out in some other large cooperative studies out of Europe that have looked at high FeNO, which seems to be a pretty good predictor of exacerbations compared with eosinophils. So the question is, why would we have an effect in non-type 2 asthma? And if we think back to our initial slides and the effects that TSLP has on a host of innate and adaptive immune cells, that I'm going to put my money on the mast cell as probably the cell of importance, and potentially the ability of TSLP to activate mast cells and the release of interleukin-8, which could give rise to a neutrophilic asthma. Other candidates may be important as well, but I think that may end up really garnering a lot of attention as we move forward. Here we're looking at lung function. We're looking at placebo in gray, where there really was no change. But usually we do see an improvement with placebo. And in this case, lung function was extremely stable. And we see an improvement across the 3 study arms. And we're looking probably at about a 9 to 12% improvement over placebo. If we look at patient-reported measures of asthma, and here we're looking at the ACQ-6, which does include FEV1, and we're looking at the 3 different active arms. And what's interesting is that early on, probably at 2 to 4 weeks, patients start to look like they're feeling better. And again, this early of onset will have a lot of importance with regards to patient adherence. And this is something that, in fact, may be observed. So we know now that we're an upstream molecule. We're blocking the generation of mature Th2, allergen-specific Th2 cells, and we're blocking the activation of ILC2s. So the question is, are we going to successfully block biomarkers that affect both IL-5 and IL-4/13? And here's the answer to that question. We're looking at blood eosinophil counts, again, extremely stable in the placebo group. And we're looking at the mean change, which was in the high 200s to low 300s, and we're dropping by 200 cells per microliter. So we're getting about a 70% drop in the highest dose group from baseline. Similarly, if we look at exhaled nitric oxide, we're seeing variable levels of NO reduction. We're seeing about a 10 part per billion drop, 10 to maybe 14 part per billion drop from placebo, which again is in the neighborhood of about 30 to 35%. And we see, interestingly, a reduction in serum IgE that continues throughout the study. So from left to right, we're seeing effects on IL-5, IL-13, and most likely IL-4 with limited effects of IL-13. And that we're not seeing a plateau of the IL-13 as we see with these other biomarkers, but at least in one of the dosing groups, continued drop. So this upstream strategy does seem to affect two of the classic pathways or effector pathways of type 2 biology, the IL-5 and the IL-4/13. Now, we don't often see measurements of cytokines. Part of that is because previously it was difficult to have assays that were sensitive enough. But here we see the results of cytokine assays. This was submitted to the ATS meeting and accepted for publication as an oral abstract, but that hasn't happened yet. So we're seeing a 61% in IL-5. We're seeing a 50% drop in blood eosinophils, and this is from the 210 milligram dose group. We're seeing a 50% drop in IL-13, about a 25% drop in exhaled nitric oxide, 20% drop in IgE, a drop in periostin, which there's an article in Press and Jackie in Practice that talks about probably the lack of any clinically meaningful relationship between periostin and other outcomes. And then finally, the T-cell chemokine TARC, a drop there as well. And these things really all infer, again, that you're blocking two of the main pathways coming out of ILC2s, Th2 cells, and mast cells. Now, when you're this far upstream, there's always a concern that you may have more side effects. And in this case, when we look at least one serious AE, we don't see any difference between these. We don't see an increase in infectious complications. We didn't see any kind of predisposition to pneumonia or any other severe pulmonary infectious process. So in the era of COVID, how would this drug fit in? Since we have seen a group of patients, and this was recently published upon, who had very, very poor prognosis, who had a very strong pulse or release of IL-4 and IL-10 during the infection, and those people ended up having fatal outcomes. And these were in asthmatics specifically. You could, I think, hypothesize that there is an important link potentially between COVID infection and in certain predisposed patients to a spike in type 2 pathology. And in that situation, drugs that do block type 2 pathology, like dupilumab, like Tezepelumab, and we don't know as much about the anti-IL-5 drugs because that really is focused strictly on IL-5 and eosinophil generation. So I think there I would reserve judgment, but there may be a cause in this very heterogeneous group of patients with asthma that there may be patients who benefit from cytokine blockade. So what we've learned today is TSLP is really a pleiotropic cytokine. It's upstream, coming out of the epithelium, has effects on lots of different cells. It's probably not a cell type that isn't affected by TSLP. We know from some very elegant studies that it's a key trigger not only of asthma caused by allergens, but by viruses and pollutants, particularly tobacco smoke. When we now look at the inhibition of the molecule in patients with mild allergic asthma, Tezepelumab had not only effect on physiology, implying probably a role for mast cells in this disease, but a role in blocking the generation of cells and mediators that are related to TSLP. And finally, in patients in a phase 2b study, we saw a very robust reduction in exacerbations, which occurred irrespective of type 2 biomarker status. We saw improvement in pulmonary function and asthma control. And I think for the first time published, we're seeing the effect of a cytokine blocker on cytokines as well as type 2 biomarkers. So I'd like to stop there. Thank everyone for attending and listening. And I'm here for questions if there are any.
Jonathan, excellent. Thank you. Do you hear me?
Is everybody still on?
Yeah. Do you hear me? Apparently he doesn't. Do others hear me?
Yes, I can hear you.
Yeah, Jonathan, you don't
I can
hear
hear
us?
For some reason, the audio from you to me
Yeah.
has been blocked. So there's a very generous offer by Amal Kamboj, who's also listening. and he's going to take the questions and text them to me if there are any questions.
So
thank you, Amal.
Ask him, it doesn't look like there's much of a dose response with this molecule.
Len Allman asked the question, is there a dose response with this molecule? Probably, we didn't see it with exacerbations. It probably doesn't take a lot of this Tezepelumab to block it. We probably could have gone lower and before seeing a diminution of that effect, but there may be in fact an effect on other outcomes, like patient-reported outcomes, that we'll probably see potentially more clearly with the phase 3 data because of a mixture of effects on both patient-reported outcomes and exacerbations. The 210 milligram once per month was the dose picked for phase 3. Any other questions?
Well, the other question I have is we usually group IL-25, 33, and TSLP together. He had commented that this is probably a more relevant molecule than 33. What about 25?
The next question, we usually group IL-25, 33, and TSLP together. You commented this is a more relevant molecule than IL-33. How does it compare to IL-25? There's a lot of redundancy between these three, as we know. And one way of sorting out the redundancy is to pick a molecule and put it into the system and see what happens, which is kind of what we did. Tezepelumab was the first drug to really reach the point of clinical development where you could put it into a group of patients with uncontrolled asthma. And it had a very profound effect. We know from some studies that have come from Regeneron, it hasn't yet been published, but where they combined dupilumab, the IL-4/13 receptor blocker, with an anti-IL-33 molecule. And what they reported in the press release is that the IL-33 inhibitor was not as good as the dupilumab, and there wasn't any synergistic effect. So with data like this, and there's data with the ST2 IL-33 receptor that was done by Genentech, and I have not seen data for that yet. But this is the kind of data using humans as the knockout model where we can sort of help to parse out what are the various contributions of these. So IL-25 specifically, in regard to your question, is the least studied. What's interesting is IL-25, also known as IL-17E, was subjected to an inhibitor in a study by Amgen with Brodalumab, which blocks not only IL-17 but IL-25. And in that study, which was not segregated by phenotypes, they did not really see an overall effect either on asthma control or exacerbations, and attempts to look at that in a post hoc fashion did not generate any meaningful reductions in their primary endpoint. So I think in that particular situation, what we know thus far is, at least with that inhibitor, IL-25 didn't seem to play a big role, again, using a human knockout. So I think at this point, TSLP certainly seems to be a very relevant target. There may be other phenotypes, however, where this really is important. And one of those phenotypes may potentially be for IL-25 and IL-33, viral infections. So maybe not as heterogeneous as the effects that we see with anti-TSLP, but specifically for viral infections, both of those molecules may play a potential role. Thank you for that question. Any other last questions before we leave today?
He can't hear us, but anybody listening.
All right.
Go ahead and
Well,
ask.
thank you very much. Hope you enjoyed it. I'm about to leave the Zoom meeting. Thank you.